The average age of menarche has remained stable at approximately 20 to 13 years over the past 80 years in well-nourished populations in developed countries. Irregular cycles occur most frequently within the first 2 to 3 years after menarche. Although this is normal during this time frame, cycle length should still be approximately 21 to 45 days, with the menses lasting 2 to 7 days. So how do we quantify normal versus heavy menstrual bleeding? A normal blood loss is 30 milliliters per cycle or 3 to 6 pads or tampons per day, with the cycle lasting about 4 to 5 days. Heavy menstrual bleeding refers to cycles lasting more than 7 days or a blood loss of greater than 80 milliliters per menses. Blood loss affecting the quality of life and adolescent well-being warrants investigations, and adolescents often do not quantify volume of menstruation very well. So if they are changing a sanitary product every 1 to 2 hours, is this deemed excessive, especially if menses is longer than 7 days? So to illustrate what we are going to talk about, we have this case. We have Miss X, a 12-year-old who presents to our OPD on the 6th day of her cycle with heavy menstrual bleeding with passage of clots. She's had a menarche a year back. First 6 cycles were normal and regular, but for the last 6 months, her cycles are heavy with the passage of clots, and the periods last for 6 to 7 days. She's not on any other medication. There is no history suggestive of any thyroid disorder or any other medicines. There's no history of bruisability or bleeding from any other site. On examination, her height is 4 feet, she's 35 kg, BMI 19.8, her abdomen is soft. Local examination, vulva, vagina looks healthy and no signs of trauma or lacerations. On investigation, we find her hemoglobin is 9.4, sugars are 97, and thyroid is 3.4. So, keeping this patient in mind, how do we classify abnormal uterine bleeding? What is the incidence? And what are the etiological factors we should look for? So, abnormal uterine bleeding is a common menstrual symptom among female adolescents. The incidence, it affects 3 to 20% of reproductive age females, with a higher incidence of up to 30% in adolescents. The definitions of abnormal uterine bleeding: any aberration of menstrual volume, regulation, duration, or frequency in a woman who is not pregnant. Heavy menstrual bleeding is a clinical presentation of AUB. Again, periods lasting more than 7 days or loss of 80 ml of blood per cycle, changing a pad or tampon every 2 hours. Symptomatic anemia in the patient, or if she is having lifestyle disturbances. The previous definitions were menorrhagia, metrorrhagia, hypomenorrhea, polymenorrhea, which we do not use nowadays. So what do we look at in the pathophysiology? Now, 80% of adolescent AUB is due to an immature hypothalamic pituitary axis. But that is a diagnosis of exclusion. So we have to keep that in mind, but we need to rule out certain other features like pregnancy, sexual trauma, any infection, regardless of the sexual history given by the patient. So a urine pregnancy test or beta HCG should be obtained. If indicated, a sensitive pelvic examination and STD infection testing should also be performed. What are the most common causes to be ruled out in this age group? So we look at hormonal imbalances, which are anovulatory cycles, PCOD, thyroid disorders, bleeding disorders, which constitute 20% of reasons for AUB, infections, trauma, medications, pregnancy. Now, FIGO defines the etiology of AUB as the palm coin classification. In adolescents, structural would be less. We would look more at non-structural causes. And in these, we would look at coagulopathy, ovulatory dysfunctions, and iatrogenic, any drugs that the patient has taken. How are we going to evaluate this patient? Now, one is her presentation. She presents with heavy and prolonged bleeding, fatigue, dizziness, abdominal pain, anxiety, mood changes. History. History is a very important tool in the evaluation of such patients, and the history should be taken with the patient and her attendant, and sometimes with the patient alone, because the patient may want to give us some history, she may not want to reveal to the attendant. So we look at her menstrual history, her sexual history. Does she have a history of contact? Has she had any discharge? Has she had any other treatment for any sexually transmitted disease? Her medical history, Is she on any medication for any reason? Her family history of bleeding disorders in her or her family, social history of any drug intake, alcohol, nicotine intake. On examination, we assess her blood loss patterns. We take her blood pressure, her pulse to look for hemodynamic changes, calculate her BMI, look for any thyroid swellings, acanthosis, acne, hirsutism, galactoria, abdominal mass, ascites, local examination if she allows it. Assessment of blood loss, again verbal, we can do it pictorial, we have pictographs, we have charts which we can show the patient and ask her, is this the amount of blood loss she is having, or evaluate her using a menstrual calendar. Talking about endocrinopathies and AUB in adolescents. Now PCOD is again very common in adolescents, and patients with obesity, hirsutism and acanthosis nigricans should be evaluated for PCOS. It can be challenging in adults because irregular menses and acne are common in adolescents and both may coexist as well. So the lab tests which we should do are total of free testosterone, a 17-hydroxyprogesterone, androstenedione, dehydroepiandrosterone sulfate, luteinizing hormone, follicle-stimulating hormone, and estradiol. We can also do a metabolic laboratory test which includes the metabolic panel and hemoglobin HbA1c. Thyroid dysfunction, again, can be evaluated by asking about a history of heat or cold intolerance, palpitations, fatigue, hair, skin or nail changes, weight gain or weight loss. And thyroid-stimulating hormone levels should be evaluated because both hypo and hyperthyroidism can cause AUB. Prolactin disorders in AUB, again, a prolactin level should be checked to evaluate for hyperprolactinemia. Medications like antipsychotics can cause elevated prolactin levels. Prolactinomas may be there suggested by values greater than 100 nanograms per ml. They can present with headache, visual field disturbances, and galactoria. So how would a patient present to us? Two major presentations: skipped periods or too much bleeding, and acute anemia. Because of frequent anovulatory cycles, adolescents may have heavier blood loss. They may present with acute anemia requiring emergency treatment and hematological evaluation. So what is our initial management? We need to assess the patient for a medical stability, triage to emergency care if necessary. Now, if she's come to our OPD with the complaints of heavy bleeding, irregular bleeding, weakness, dizziness, yes, we can manage her in the OPD. If she's brought to the casualty with a history of heavy bleeding of the past 4 or 5 days and she has a thready pulse and a low blood pressure, then yes, we need to give her emergency care. We take a detailed history regarding menarche, intervals between menses, duration of bleeding, amount of bleeding, and look for signs and symptoms of anemia. A family history of bleeding disorder should be obtained in addition to assessing the patient for easy bruising or glum bleeding, because 20% of adolescents with heavy menstrual bleeding have subsequently been found to have a bleeding disorder. Screening tools like the pictorial blood assessment is helpful, as is the menstrual calendar. Now, we have a recommended screening tool for adolescent patients who report heavy menstrual bleeding. If she meets one or more of the following criteria, it indicates a positive screen result and warrants further evaluation. Menses greater than 7 days and flooding or gushing sensation or bleeding through a pant or tampon in 2 hours, a history of anemia, family history of a bleeding disorder, a history of a bleeding disorder after a hemostatic challenge like tooth extraction or any surgery. If a patient meets one or more of the screening criteria, she warrants further evaluation. So this is just a chart showing the lab evaluation, the specific tests which we need to do in a patient who comes to us with AUB. So the initial lab testing involves a CBC, the blood group or pregnancy test, lab evaluation for disorders of hemostasis. So we have a PT, APTT, fibrinogen level, testing for von Willebrand's disease, and other tests to consider are the thyroid function test, serum iron, total iron binding capacity and ferritin, liver function tests, and tests for STD like chlamydia and Neisseria. A routine ultrasonography should not be obtained solely for the workup of heavy menstrual bleeding in adolescents, but it should be considered for patients who do not respond to initial management. So coming to the management, Now, it is important to understand the cause of AUB to direct the therapy. We need to rule out pregnancy, infections, structural causes, and thyroid conditions, and tailor the treatment as per the cause. Management would be either hormonal or non-hormonal. Now, if we do medical management, the non-hormonal options we have are hematinics, iron supplements to build up the iron levels, antifibrinolytics like tranexamic acid, aminocaproic acid, non-steroidal anti-inflammatory drugs like mefenamic acid, naproxen, brufen, or we have the hormonal treatment, which is a combined estrogen-progesterone pills, the progestogens, LNG-IUS, GnRH analogs, and estrogen. Among patients who are found to have a bleeding disorder, the management should be coordinated with a hematologist. In the event, other factors or blood products need to be administered concurrently. And for patients who are anticoagulated, working with a hematologist regarding the options for reversibility of anticoagulant therapy to control the AUB is also important. What are the goals of management? Hemodynamic stability, correction of anemia, re-establishing a normal menstrual pattern, and prevention of recurrence. So, in the acute setting of blood loss, the first priority is to stabilize the patient. Determination for admission will be based on whether the patient has symptomatic anemia requiring a blood transfusion. Once admitted, stabilize with blood products and initiate medical therapy. But before giving her any blood or blood products, one should always take the blood samples, the routine samples for CBC, thyroid, and iron levels, plus the samples to rule out any bleeding disorder. And when starting hormonal therapy, iron therapy should also be administered, whether intravenously or orally. Depending on the patient's medical history and ability to tolerate oral intake, estrogen-containing options may also be considered. The first-line options in this acute setting include intravenous conjugated estrogen and oral contraceptive tapers. After immediate stabilization with intravenous conjugated estrogen, patient can be transitioned to an oral contraceptive taper with the goal to titrate down eventually to 1 pill per day. So this is just a brief overview of how we can manage acute HMB in the IPD and OPD. So if she comes with heavy bleeding, we give her conjugated estrogens, 25 milligrams IV 4 hourly, maximum 6 doses. We can also give her tranexamic acid, 10 milligram per kg body weight, 8 hourly, or aminocaproic acid, 4 to 5 grams loading dose, and then 1 gram per hour as maintenance. Follow-up in the OPD, we can give oral progestogens, NPA 60 to 120 milligrams, then 20 milligrams TID for 7 days, maintenance for 21 days. Combined oral contraceptive pills, monophasic pills, 3 times a day for 7 days, then 1 daily for 21 days. Oral antifibrinolytics like tranexamic acid, 1300 milligram, 3 times a day, or 2 to 3 grams per day in divided doses can be used. Coming to tranexamic acid, which is really very used very frequently by all of us, it reduces the blood loss by 50%. Large doses are required orally, as I have said, and the incidence of GI side effects, intermenstrual bleeding are relatively high. Risk of thrombogenic disorders is also a concern. NSAIDs, again widely used in the management of AUB. They reduce blood loss by 25 to 30% because they inhibit the vasodilating prostaglandins, permitting vasoconstrictor PGs to inhibit the excessive menstrual blood loss. Commonly used are mefenamic acid and naproxen, but they are less effective than tranexamic acid. Side effects are gastrointestinal disturbances and headaches. What are the guidelines which we should be following treating some patients? So we have to look at the menstrual bleeding and the hemoglobin of the patient. So we can classify them as mild, moderate, and severe. If she has mild alteration in her cycle, that means her cycle is more than 7 days but less than 24 days with a slight increase in blood flow, her hemoglobin is more than 12 gram%, then we can manage her with iron, NSAIDs, reassurance. If her bleeding is moderate, that it lasts more than 7 days and comes in less than 21 days with increased flow, her hemoglobin is 10 to 12 gram percent, then we need to put her on monophasic OC pills with a 30 to 35 microgram of estradiol PD. Taper to one dose OD once the bleeding stops and continue it for at least 6 months. We can also give her norethindrone acetate 5 to 10 milligrams or MPA 5 to 10 milligram 4 times a day, followed by tapering to once daily over 2 to 3 weeks. If, however, she is she is severely bothered, she has disruptive cycles, her hemoglobin is between 8 and 10 grams per DL, but she is hemodynamically stable, we can consider initially intravenous estrogen, 25 milligrams 4 to 6 hours for 1 day, or OC pills and taper gradually. If she is severely anemic and she is hemodynamically unstable with a hemoglobin of less than 7 gram per DL, we need to admit her, consider blood transfusion, intravenous estrogen or OCPs, and add antiemetics. The most commonly asked question is, okay, we're giving her estrogen progesterone, now it's going to affect her growth and her epiphyseal closure. But studies have shown that this is not the case. And by the time the girl reaches menarche and she started her periods, 90% of her growth cycle is already complete. So the advantages are more than any disadvantages which may be there. What is the role of LNG IUD? A lot of people do put, even in the West, I think a lot of teenagers are being advised to take an LNG IUD. It has a two-pronged effect. One, it is reversible and it also gives a contraceptive method. It has minimal complications with a higher rate of adherence. You do not need to pop a pill every day. Once the Mirena is inserted, it's there. But we do not have so much data in our adolescent group and we must manage along with a hematologist. Now, talking about hematologists and everything, we come to what bleeding disorders can we see in adolescents? Because sometimes the first time we are aware of a bleeding disorder is when she comes with heavy menstrual bleeding. So there are a number of tests which we can do. So 20% of adolescents bleeding with heavy menstrual bleeding have an underlying bleeding disorder, and most common is von Willebrand's disease. So this is a list of diagnostic tests for bleeding disorders, for von Willebrand's disease, for platelet factor dysfunction, for thrombocytopenia, and coagulation factor defects. What are the other investigations we can do? We do a complete blood cell count with platelets, prothrombin time, partial thromboplastin time. Sorry. Management of blood dyscrasias. Now, if she has low platelets, if she is diagnosed as ITP, we give her steroids. If non-ITP, consider random donor platelets or single donor platelet. If she has a platelet function defect, we give antifibrinolytic agents like tranexamic acid or epsilon aminocaproic acid. Avoid NSAIDs. If uncontrolled, consider giving platelets to raise her platelet count by 50,000 per micromole. For von Willebrand's disease, antifibrinolytics, desmopressin, avoid NSAIDs. If uncontrolled, consider factor replacement with von Willebrand factor containing factor VIII preparation, which may be plasma-derived or cryoprecipitate. Any coagulation factor deficiency, look for factor replacement, plasma-derived or recombinant. All these need to be done in conjunction with the hematologist. We come to a couple of other reasons why the patient may have abnormal uterine bleeding: iatrogenic causes, medications like anticoagulants, hormonal contraceptive which she takes irregularly, or any other medication known to interfere with ovulation like antipsychotics. So a proper history needs to be taken as to her what medication she's taking. This is a very rare occurrence because the incidence of endometrial cancer in women younger than 20 years is low. In patients whom medical treatments have failed, who have risk factors like genetic conditions, morbid obesity, prolonged history of anovulatory cycles, evaluation of the endometrium may be warranted. So to conclude, I would say the most common cause of heavy menstrual bleeding in adolescents is anovulatory cycles, but it is a diagnosis of exclusion. Hormonal therapy aims to stabilize the endometrium. The primary therapy is medical. We must consult a hematologist when the bleeding disorder is there or primary treatment fails. We must rule out any form of infection in the patient. We must educate the patient and her family, institute lifestyle modifications, and emphasize the importance of regular follow-up and continuation of treatment so we can manage these girls much better. Thank you.